Okay. So we're going to start out with a question. This is something you should be referencing that very last slide that we got to last time to figure out. So we were talking about how we can figure out whether on the whole we have secretion or reabsorption happening as we pass through the nephron and out the kidney. So we're looking at a measurement of a specific molecule, PAH. So we're looking at the filtered load going into the nephron versus how much is being excreted. We're just trying to figure out whether on the whole we were reabsorbing or secreting this into our bloodstream. Okay, not a lot of votes, but let's take a look. Okay, cool. So most people who answered got this right. So this would be an example of secretion. So all we're doing when we look at this figure is we're trying to use our understanding of the directions of fluid and solute flow in order to understand function of the kidney. So we know that filtration is happening up at the beginning of the nephron. So filtration movement from the glomerular capillaries into the nephron. So you're going to start out with some amount of your substance in the nephron in the kidney. Eventually at the opposite end, all right, as fluid exits your kidney, goes into your ureter, your bladder, out your urethra, that's excretion. So this is pretty simply when we have more of something in our urine than we were filtering in per minute into our nephron. That means it had to come from somewhere. So it must have been secreted from later parts of the nephron, from the peritubular capillaries into the filtrate, past the point of filtration. Or on the opposite side on net, if you see a lot of something being filtered into the nephron, but when you check the urine, there's not much left. That means that we had a lot of reabsorption happening. So that's all this is. All this is showing is that relationship here. So when we're trying to figure out our excretion rate, we would be paying attention to our filtered load, our secretion rate, so the amount of extra that's going into the nephron later on, reabsorption rate, so how much is coming out of that filtrate and going back to the bloodstream, will give us our excretion rate. Now those secretion rates and reabsorption rates aren't directly measurable usually. So usually we're using the two endpoints, the filtration and the excretion rate, to make estimates about what's happening inside the kidney. That's kind of the point here. So we can see how that works. If we zoom in a little bit, all right, so if we have a solute, we start with a certain amount filtered into the kidney. Anytime we secrete additional amounts, we're going to add those in. Anytime we reabsorb, reabsorption is moving back into the bloodstream. So we'd subtract those away, giving us an excretion amount. Okay. We could also do this with water, right? So water would behave the same way, right? So we have a lot of water filtered into the kidney. We're not going to see much secretion happening here, but we will see an awful lot of reabsorption of water, which is part of why you are not urinating like 100% of the time, 100% of your life. Okay. So the final topic here is just kind of A little bit of a mention of this idea of clearance. So clearance is something that you may measure in clinical courses in the future. What the basic idea of clearance is that we could calculate essentially an amount of blood that you've fully removed some substance from. Now, this is not an actual chunk of blood that you could put into a bucket, right? This is kind of an imaginary amount of blood. Sometimes it will be more than potentially all the blood in your cardiovascular system, depending how fast we're clearing something. So I don't expect you to know these equations, but this is kind of how that would work. So what we'd be looking at if we were trying to measure clearance is we'd be comparing, except in this time in division form, the excretion rate of a substance, so how much is coming out of the kidney, versus how much we have in the plasma concentration in the first place. And that ratio is going to tell you essentially how much is being excreted per hour. And we're going to get a measurement essentially of like clean plasma there. So here's the clearance rate of some molecules that are relevant to kidney function here. So we've got the PAH, that was our example. This is something they'll often like give you to help test kidney function: creatinine, inulin, potassium chloride, sodium, and glucose. Okay, cool. And you'll notice that glucose, right, should be 100% reabsorbed. So we should not be clearing out any of the glucose from our plasma, right? Because we shouldn't see any of that excreted out. We should be reabsorbing all of it. So these numbers up at the top, these much larger numbers, those would be like what we think of as waste products, right? We're actively trying to excrete these from the body. Okay. So we're going to move on to thinking about water next. Okay. We're going to start out by mentioning some of the relevant structures to our water balance and identifying this concept of balance. So when we're thinking about water conservation and water movement, we're going to be thinking about the loop of Henle. So that's this loop here. So this is going to be really important as it dives down into the medulla. Okay. And as we start to think about reabsorption of water, we've already mentioned that our proximal tubule is the mass reabsorber. So we already know the proximal tubule is doing a lot of reabsorption. But we are going to move into thinking about our distal tubule and our collecting duct in addition to that proximal tubule. So this is where we're going to start to see regulated reabsorption, where we're going to start to see hormone signaling, indicating to the kidneys how much water we actually want to be reabsorbing, how much water we want to be losing. So the loop of Henle is going to be creating the conditions necessary to concentrate our urine and minimize some of our water loss. And then those other locations are going to be where the actual reabsorption is mostly happening. Okay. So the idea of balance is really what it says on the tin, right? This is a normal English word. We're trying to balance, in this case, how much water you take in to how much water is coming out at any given time. So your water intake is going to be the water you drink, but it's also going to include some water that you produce metabolically. So water is a byproduct of some chemical reaction. So we would count that in our intake column, the going in part. Our going out part, our output for the water balance that we're trying to physically balance, right? It's going to be partially something called insensible loss. So think of like water vapor that you breathe out during expiration. You don't notice it. So that's kind of getting to that insensible part. Sweating, you're removing water. Your GI tract and your kidneys are going to be excreting water as well. So in feces and in urine, we have some water content there. So if you're in balance, these should all add up such that your input of water, so the amount of water you drink and the amount of water you make, matches the amount of water that's coming out, whether you're breathing it out whether you're sweating, or whether you're excreting it as feces and urine. So we're in balance if our solutes and water enter and exit the plasma at the same rate. We're focusing on water right now, but this concept is going to be the same when we think about solutes like sodium and potassium. So if the amount is coming in is the same as the amount going out, our quantity of that substance, right? So our amount of water in our body is going to stay the same if you've got the same amount coming in as the same amount going out. Now, this might not always be the case in your day-to-day life. So sometimes your water intake is going to be greater than the output. And in that case, we'd refer to your state as being in positive balance. So that means that because we're adding more in than we're taking away, right? Your total level is going up, right? So you're becoming more and more hydrated as you're in this positive balance state. Negative balance, you want to think dehydration, right? So you're not drinking very much water, you're not making very much water, but you're losing a lot. Maybe you're sweating really heavily, right? So you're pulling down your reserves of water here as you're in negative balance. Now, water balance matters in part because water is directly tied to your blood volume, right? Your blood is a liquid. That liquid is mostly water. So in order to maintain blood volume and therefore maintain blood pressure, you have to keep enough water in your body. We don't want to be in negative balance all the time, losing water, or we're going to start to have problems with our cardiovascular system, start to have problems with blood pressure because we just physically don't have enough blood going around. So our normal blood volume is going to be referred to as normovolemia. So normo for normal, volemia for that volume of blood. Okay. We have states corresponding to that positive balance and negative balance as well. Okay. So if you're in positive water balance, you're adding in lots of water, not taking much away. You're going to end up with hypervolemia, so extra volume, volemia. Or on the opposite side, if you're getting really dehydrated, you're not drinking much water, but you're sweating a ton, potentially, you're going to end up in hypovolemia. So hypo for low, volemia for that volume of blood. Okay. So this is part of why we care about kidney function, because we would like to keep ourselves at an appropriate amount of blood in our bodies. We would like to have normovolemia, no problems with blood volume. So to do that, we can't let all the water that's coming into the kidney being filtered into our nephrons escape and be excreted as urine, because we have lots and lots of fluid coming into those nephrons every minute. Okay. So fortunately, after that fluid is filtered into Bowman's capsule, it enters the proximal tubule. And last time we mentioned that proximal tubule is really made for lots of unregulated reabsorption. And we mentioned that as we have solutes like sodium and chloride being reabsorbed into the bloodstream and the proximal tubule, the water is basically following along. So a lot of water is being reabsorbed, moving back to your bloodstream pretty immediately. And the water is going to pass through the loop of Henle, which we'll talk about what's happening there. Right? That's going to be really, though, setting up a state that changes the kidney properties and changes how much they pull on water, so that as we move into the distal tubule and down into the collecting duct, we have enough osmotic pull on water to pull back potentially even more water, right? So we're going to have regulated reabsorption in the distal tubule and collecting duct. We're going to need to be traveling through a essentially saltier and saltier kidney as we descend towards the renal pelvis, so we can concentrate urine more and more and pull more and more water back into the bloodstream so you don't lose it as urine. So about 20% of the additional reabsorption that happens is going to be in the distal tubule, and another 10% will happen as our nephrons combine and flow into collecting ducts. And the hormone that's going to be regulating them in these areas is something called ADH, or antidiuretic hormone. But before we get to that, let's remind ourselves of the concept of osmosis. All right, so water diffuses down its own concentration gradient. So from where there's lots of water to where there's not very much water. We don't often give water concentrations though, so it's helpful to realize that water concentration and solute concentration are going to be inverse of each other. They're going to be opposites. So we're going to see that water is essentially being pulled towards solutes, right? So when you have lots of, say, ions, lots of impermeable solutes, but we're often going to see sodium as one of them, right? We're going to see water moving towards high concentrations of solutes. So in this way, our water reabsorption follows our solute reabsorption. All right, so we can draw that just real quick. All right, so if you have a lot of water somewhere, that means you only have a little solute. If you have a lot of solute, that means you only have a little bit of water. Okay. So when we see water moving down its gradient, if you back solve and figure out how much water there was in that area, you can get this direction. But you can also sometimes skip that extra step and just look at that high concentration of solutes. Okay. So because of the structure of our nephron, as we move through the kidney, we're going to be dipping in and out of the medulla. Okay. So we're starting out here, the top, in the renal cortex. So cortex is like the shell of something, the outer part. So you can see here for this nephron, and that's where we have the glomerulus and Bowman's capsule. That's where we have our proximal tubule winding around. But then we start to descend here into the loop of Henle, into the medulla. So there's kind of a dividing line here, and you can literally see this dividing line in the kidneys in lab. Okay. Now, the medulla is going to have different properties than the cortex, and specifically, we're going to see in the medulla that it exerts a greater pull on water. Okay. So we refer to this as an osmotic gradient, this difference that we're going to see in how hard the different parts of the kidney are pulling on water. So that's the osmotic part. And it's going to get set up by the properties of the loop of Henle and the blood vessels that neighbor them. So we call this the countercurrent multiplier, because if you'll notice, the two parts of the loop of Henle are right next to each other, but our arrows are going in opposite directions, right? So down is right next to up, right? And if we compare blood vessel to the loop of Henle, we can see that for our blood vessel, the neighboring part of the loop of Henle is also going the opposite direction to that, right? So counter opposite current, the flow, right? So the counter current multiplier is setting up the properties of the medulla. Okay. So the key takeaways here are going to be that our osmolarity of our interstitial fluid, so that fluid in the spaces between the cells in the renal medulla, is going to change depending on how far down you are into the kidney. So we're going to have lower osmolarity when we're up near the cortex, and we're going to get greater and greater and greater osmolarity as we near the renal pelvis. Okay. So when we're thinking about that positionally, cortex is the outer shell, the pelvis is where everything is going to in the middle here. So what we're saying is that we're going to have greater and greater osmolarity as we run towards the middle here. Okay. So in terms of numbers for osmolarity, I think we briefly touched on this at some point in A&P 1. We're not going to do calculations here, but I do want us to remember that essentially you can think of those numbers for osmolarity as how hard is this area pulling on water. So a lower number, when we say we have lower osmolarity near the cortex, that means we only have a slight pull on water. As we move down to these higher and higher numbers, so you can see we get to 1400 here in the deep parts of the medulla, that's a really strong pull on water. Okay. So that's what these are indicating as we're looking at this gradient, right? So here's this gradient. We're gradually going up and up and up in osmolarity as we move down. Okay. So in reality, our nephrons are all twisting around each other. But for our purposes, it's going to be helpful to think of them in a step-by-step kind of way. So here we see that when we think about our fluid that's traveling through, in our proximal tubule, we're going through the cortex, right? As we move into the loop of Henle, we dive into what we refer to as the descending limb. So descending because it's going down. So here we're going to see some water movement into the renal medulla, right? So we do have a pull on water because of this medullary osmotic gradient. As we enter the ascending limb, so going up through the loop of Henle, that's our ascending limb of the loop of Henle, we don't see water movement anymore because this part of the loop of Henle is not permeable to water, so it can't get across the walls here. We don't have space for it. Instead, what we have are solutes being pumped into the medulla, right? So the effect of moving all these solutes, all these salts, all these ions into the renal medulla, because solutes pull on water, right? Solutes are creating those higher numbers in our medullary osmotic gradient. So this is what's making the medulla have such a pull on water, right? So when you think about water movement and you're looking at the medulla, better not to think about it necessarily through order, although you do want to know what happens in the different parts of the nephron. But you want to notice anytime we're crossing through the medulla and water is able to travel through, we'll see water traveling here as well, right? We're going to be reacting to that pull on water just because of where we are in this physical space. Okay. So your book goes through a whole setup as to how this medullary osmotic gradient is established. But what I want us to really focus on is what the result is, right? Because you are not currently establishing your medullary osmotic gradient. It has been established in your body for like your whole life, right? So this is the reality that you're dealing with on a day-to-day basis and that any patient you encounter will be dealing with. So our results are that as we move through the medulla, we end up, I don't like that color, right? So we started proximal tubule, went into the loop of Henle. Then we have our distal tubule and the collecting duct. We're going to have a situation where your cortex is at 300 milliosmoles. And that's going to be true regardless of whether proximal tubule or distal tubule is flowing through that area, right? Because that's just a property of the kidney, okay? But these later parts of the nephron, as we move through the distal tubule, are going to have a pretty low osmolarity, right? So we're going to see an osmolarity of 100 milliosmoles in the fluid that's passing through the distal tubule, which is part of why I guess really the main reason why, we'll see that we are able to reabsorb water in this area, right? Because we're going to be comparing the osmolarity of our fluid, which is 100, to the osmolarity of the region we're traveling through, which is 300. Okay, so we have a greater pull here, even from the cortex, when we have this low osmolarity of the fluid traveling through it. When we're looking at the medulla itself and those renal pyramids, we're going to see way bigger numbers, right? So those ones will be a little more obvious as to why there's a pull. They're just highlighting that there's still a difference between the distal tubule, even though we're traveling through the cortex again and we've come back up. Okay. So ascending limb of our loop of Henle is one of the first things we should focus on, even though it's the second place that our fluid is going to flow. The reason we're focusing first on our ascending limb is because this is what's setting everything up. So here we can see that in the ascending limb, we have active transport of sodium and chloride, not drawn on here, but also potassium. So we're actively using energy, we're actively using ATP to pump solutes out of the fluid here. So that's part of why we have those low osmolarity values for the fluid that's in the distal tubule. You can see as we're pumping salts out, right, our osmolarity is going down. So as you remove solutes, that drops down the osmolarity of the remaining fluid because it's more watery now, right? We took salts out of it, now it's more watery. In the descending limb, where the fluid flows first, we're not transporting any of our ions. What we are going to transport is some water. So in the descending limb, we have tissue that is permeable to water, so water can move, so it does. All right. If water could move in the ascending limb, it might, depending on what region it's flowing through, but it can't ever be reabsorbed by that as it moves through that ascending limb, because we don't have the appropriate structures in our membranes of our cells in this region to allow the water through. So we usually think of water as being able to cross cell membranes whenever. This is the one time we're going to be thinking about cells that like block water from crossing through. Okay, so here's that setup picture. And so I'll just highlight a couple things, but what we really want to know. So when you're studying, what you really want to focus on is not the setup, but the steady state system that we end up with at the end, right? So the steady state system we end up with at the end is a cortex that's at 300 milliosmoles. Okay. The fluid flowing through the proximal tubule as it enters the loop of Henle is also at 300 milliosmoles. So the reabsorption happened earlier on before we descend into the loop of Henle. So we're at equilibrium by the time we reach the end of the proximal tubule. Okay. As we drop down through the medulla, we're going to see that osmolarity of the medulla going up and up and up, gradually going up, which is why it's our osmotic gradient. Okay. Has to be a gradient because we can also see that as fluid moves down, right, through here, it's also going up in its osmolarity because we have water movement coming out of the descending limb. Right, so water can come out here, which is why we need this bigger and bigger pull on it. As fluid goes through the ascending limb, that osmolarity starts to drop because we're pumping our solutes into the medulla, keeping the medulla nice and salty, keeping that pull on water strong as we're in the medulla. So we start to see this dropping. Because of the way things are pushing forward, the final osmolarity of the fluid that we're pushing into the distal tubule as it returns and goes through the cortex has that lower osmolarity than the cortex that neighbors it, which means that if water is allowed to move through this region, and that's going to be the regulated part, sometimes water is going to be able to cross the walls of the distal tubule, sometimes it's not, okay? But when it is allowed, that means we're going to have water movement towards that higher osmolarity region. So that's fundamentally what we want to understand. So I'll flip through how we got there. All right, so if you start out with an imaginary situation where everything's at the same osmolarity, right, everything's at equilibrium, that's fine. But we put in energy in the ascending limb to shake things up, right? So here's where we have that active transport. So using energy in order to pump those sodium, chloride, and potassium ions out of the ascending limb. Right, so that immediately increases the osmolarity of the medulla because that's where we are, right? So it just goes into the tissue neighboring. Okay. So once we have that medulla at a higher osmolarity, this means that we now have a pull on fluid in the descending limb. Since it's permeable to water, we have some water movement towards that region. Okay. This would briefly come to equilibrium. So we'd end up with an isoosmotic state for a little bit. Okay. But then we have to remember that the fluid isn't static here. It's not all just sitting in the same place. So as we are continually filtering fluid, so plasma and solutes, through our nephron, we're going to see essentially all these numbers push forward. All right. So our fluid coming from the proximal tubule is pushing down into this descending loop of Henle, right? And the fluid from the ascending limb is kind of pushing up as well. So we start to see differences again so that we can continue movement of water out of the ascending limb, which is what's next. Okay. So we can see that we're starting to establish a gradient here. So we keep this difference. The gradient is changing in part because this fluid is continuing to push forward. Briefly, we might cross through an isoosmotic state. As this happens over and over again, eventually your body ends up settling on this steady state system where we have cortex and proximal tubule filtrate at 300, a gradient of increasing osmolarity as we go deeper to the medulla with really big numbers when we get to the bottom. As we come back up, we're losing solutes pretty fast because we're actively pumping them, and we're also pushing that fluid forward. So we don't have time to end up in an isoosmotic state. We end up with slightly lower osmolarity in the filtrate traveling through the distal tubule. So that's our big picture again. Your book walks through that in detail too. If you want to go through it in detail, happy to talk about it. Otherwise, what we want to know are the properties of that steady state, as well as what is actually able to cross the descending limb, water, versus the ascending limb, solutes. Okay. So, summarizing what we just said, what characterizes the osmolarity of the deep parts of the medulla? Are they highly osmolar or do they have low osmolarity? And where were we pumping out those solutes? This is our major takeaway that we want to get from this loop of Henle stuff. osmolarity in the deep parts of the medulla as we're near the renal pelvis. So like at the base of all the pyramids that you'll see in lab, we have really high osmolarity, which means a strong pull on water, big numbers. The reason that we have that high osmolarity is chiefly because our ascending limb of the loop of Henle has been pumping solutes out. So it's been pumping sodium, it's been pumping chloride, it's been pumping potassium into that region, meaning we have lots of solutes that are attracting water. Okay. So that is the main part of how our medullary osmotic gradient was established, right? And that's the main part of how we're maintaining that gradient as well. But we do have some other factors that are kind of assisting. So one of these is urea. So this is a waste product generated by the liver. It's kind of how you get rid of nitrogen. So it's also what gives urine its name, urea. Okay. So you will see this in your urine. This is measurable in your urine. It's a waste product. It's super water soluble. Okay. Now, it will sometimes cross in and out of the nephron. So there are transporters for this, so it can't do it always, right? So we can see the location of some of those transporters, right? So here we can see that we have some UTA transporters here in the collecting duct. We have some UTB transporters in the peritubular capillaries in these blood vessels that are neighboring the loop of Henle. We can see some additional transporters even up here in our proximal tubule, these UTC ones. Okay, so we're going to focus on those UTA transporters from the collecting duct. Okay. So not all of the urea ends up in the urine. Some of it gets transported out in the collecting duct as we are approaching our final concentration of urine. So when we move urea from the collecting duct into the neighboring region, right, we are in the medulla, right? Here's our division between the cortex and the medulla. So this essentially acts as another solute that pulls water towards itself, right? So this is getting added in along with that sodium potassium chloride that we've been pumping out of the ascending limb of the loop of Henle, further extending exactly how osmolar, how great a pull on water we have in this region, right? So this is part of why those numbers get so high in the deep parts of the medulla, is that the urea is kind of adding into this. The other thing we might think about are the vasorecta. So the vasorecta are the names for the straight parts of the blood flow next to the loop of Henle, right? So we had proximal tubule here with peritubular capillaries next to it, right? Then as we go into the descending limb, right, we have some blood flow here next to it. So straight part would be the vasorecta, just kind of this straight line. And as we come back up, we also have blood flow neighboring that ascending limb of the loop of Henle as well. Okay. Now this is important because we mentioned, I kind of skipped past those sections in the establishment of the osmotic gradient that involved them coming to equilibrium with the neighboring regions, right? Those pause points where we had an isoosmotic state, right? So if you just left everything sitting there in your kidney, nothing moving around and no blood flow neighboring, eventually things just like to come to equilibrium. So we could essentially wash away that gradient if we just left it as is. Now the vasorecta and these capillaries that are passing right next to the loop of Henle and diving through it, just like the loop of Henle is, helps so that we don't wash away the gradient. So the descending part of the vasorecta is at 300 milliosmoles. As it's going through, the water is going to be leaving those capillaries by osmosis. Some solutes are going to enter by diffusion. And then in the ascending limb, we're going to have the opposite thing happen, but we have a slightly higher here osmolarity. So we're going to see the ascending limb of the vasorecta, leaving water to go into the plasma, so into the blood, and solutes go into the interstitial fluid. These ones are not going to have the right urea transporters here, so we don't have to think about them. Really, what I want you to know about the vasorecta is just that they're helping that medullary osmotic gradient to be maintained here and not disappear, right? So here, be careful if you look at this figure, because what we are looking at here is blood flow, right? So this looks like a nephron, but it's not. Right. So here you can see that movement of water and solutes through both of the sides of the vasorecta, both of these limbs, the artery side and the venule side. Okay. So this is helping us take that water that's coming out of the descending limb of the loop of Henle and actually move some of it into the blood so that we don't water down the really highly osmolar parts of the gradient and vice versa. Okay. That takes us to the distal tubule and the collecting duct, which is what we really care about when we think about how the kidneys are regulating blood volume, right? So the loop of Henle is setting up the osmolarity of the different regions of the kidney, setting up in particular that medullary osmotic gradient, right, where we have low osmolarity up high by the cortex, high osmolarity deeper and deeper in the kidney, right? So we're going to use that setup of the kidney in order to do some regulated reabsorption as we move into the distal tubule and the collecting duct and kind of fine tune the concentration of our urine. So we're going to need to think about the osmotic gradient. So we're going to want to think about how strongly is the kidney pulling on water. So if it's pulling, right, water leaves the filtrate and gets reabsorbed because of this pull on water by the kidney, right? We're going to be concentrating down the urine, making less of it, making it more concentrated in terms of solutes because we're removing water. But in order to do that, we're going to have epithelium that is permeable to water, right? So for water to actually cross membranes, we have not been drawing them on this whole course, but technically the water is getting there through these molecules, these proteins called aquaporins. We just assume that any generic cell, unless we say otherwise, has aquaporins and water can move, because that is true broadly, except for these certain regions of the kidney. Okay. So the way that we're going to be able to regulate how much water we reabsorb, so we're going to be regulating those aquaporins, so those pores that allow water to move. If we turn them on, we have lots of aquaporins, we can reabsorb water as we go through those highly osmolar regions of the kidney. But if we close them off, if we don't have the right aquaporins in the right places, even though we have a pull on water, nothing's going to happen because we can't react to it because the water can't move. So when we say ADH regulates blood volume or regulates reabsorption in the distal tubule and collecting duct, what it's actually doing is kind of toggling that switch, right? So it's going to be turning the permeability of the epithelium in those regions on and off. Okay. So to think about that, we're going to be thinking about our bloodstream on the basolateral membrane. We're going to be thinking about our cell pointing towards filtrate. Okay, so here's where our filtrate is moving past. Okay, so we have two types of aquaporins. Aquaporin 3 is on the basolateral membrane, so this is always present. Okay. So if you can get water into this cell, it's going to always be able to move from the cell into the blood. What we're going to be turning on and off is the aquaporin 2 that's on the apical membrane. All right. So if it's present, great. We can get from the filtrate into the cell. Aquaporin 3 is always there, so we can get from the cell into the blood. But if we don't have that aquaporin, it does not matter how much water we have in our filtrate, in our future urine, because we can't get it into the cell, so we're not going to be able to reabsorb it into the blood. So here is the generic form of the epithelial cells in that distal tubule and collecting duct that we saw before. All right, so when we were talking about them before, we noticed that they have a bunch of mitochondria. They have really tight junctions between them rather than leaky tight junctions. That's really why this slide is back up here now. All right, so we could have some paracellular transport of water in the proximal tubule, meaning it could get between cells a little bit, but it absolutely is not going to be able to sneak between cells here in the distal tubule and collecting duct because they're really tightly sealed together here. Right. So when we're thinking about this reabsorption, our direction remains the same. Right? So water reabsorption is always going to be water moving from our filtrate, from our future urine, back into the bloodstream, keeping blood volume up. Okay. But that membrane is not always permeable to water. So when it's not permeable, water can't leave the tubules. So your urine is going to be the same concentration it was as you were leaving the loop of Henle, essentially. We're not going to be able to reabsorb any more water. We're stuck with whatever we managed to reabsorb in the proximal tubule. Everything that goes into the distal tubule goes into the collecting duct is going to come out in the urine. But if we're in a situation where you want to keep blood volume up, right? You want to not get dehydrated. You want to keep your blood pressure up. You want to keep a good amount of blood volume running through your veins. You may need to grab excess water from the filtrate, pull it into the bloodstream to do that. This would happen through osmosis. This would concentrate the urine, so you'd pee less. It would be more full of solutes. Okay. And we'll talk about how that works a little bit next time. So just a note, originally on your schedule, it said I wouldn't be here Friday at a conference over the weekend, but I managed to make my flight right after class. So I will be here. So we'll talk about what we'll talk about on Friday, but as usual, the Zoom and the YouTube will be up anyway.